Welcome back. Today we're doing a focused review on scalp and calvarial reconstruction. Really essential knowledge for, the upcoming board exams. Let's get straight into the key concepts you need.
Sounds good. Okay, first off, scalp anatomy. Understanding the layers is absolutely crucial. Remember, scalp-y.
Right. Skin, subcutaneous tissue, a ponderotic layer.
Then the loose areolar tissue and pericranium down on the bone.
And that layered structure, it's not just mnemonic, is it? That loose areolar layer, for instance, that's what gives the scalp its mobility. Key for flaps.
Exactly. And within that subcutaneous layer, that's where your main vessels and nerves run. The aponeurotic layer, the glia, that's your strength layer for closure.
And the loose layer, the subgaleal space, that's the common avulsion plane, right? Contains those emissary veins, two potential track for infection.
Definitely something to keep in mind. Then beneath that, the pericranium stuck tightly to the calvarium.
Okay, and the calvarium itself, 3 layers there too.
Yep, the external table, the diploic space in the middle, and the internal table. Pretty straightforward.
Good. Now, blood supplied to the scalp, it's impressive.
Oh, it's remarkable. Comes off both the internal and external carotid systems. You can think of it in territories: anterior, lateral, posterior, posterolateral.
But the really critical point here, clinically speaking, is the collateralization, isn't it?
Massive collateralization. It's so extensive that, sometimes a total scalp replantation can actually survive on just a single vessel anastomosis.
Which really underscores why in trauma, you should be pretty conservative with initial debridement. That tissue might surprise you.
Absolutely. Don't throw away potentially viable scalp.
Okay, let's pivot to innervation. Sensory side first.
Right. Mostly trigeminal nerve branches. You've got the supraorbital and supratrochlear from V1.
Forehead and anterior scalp.
Then zygomaticotemporal from V2, auriculotemporal from V3, kind of covering the temple and side.
And don't forget posteriorly. That's cervical spine territory.
Exactly. The greater and lesser occipital nerves. You need to know these distributions to check sensation and plan incisions.
And
motor is facial nerve. 2 main branches to consider for the scalp itself.
the frontal branch.
Right, for the frontalis muscle. Brow elevation, super important aesthetically. Damage that and you get brow ptosis.
And the other one.
The posterior auricular branch, it handles the muscles around the ear and the occipitalis muscle belly posteriorly.
Okay, good summary. What about lymphatics?
Lymphatics generally follow the blood vessels. It's a network in the subdermal and subcutaneous layers.
And they drain where?
2 nodes in the parotid region, preauricular, postauricular, upper neck, and occipital areas. Key point: no lymph nodes within the scalp itself.
Right. Now, thinking about reconstruction. The skin itself has properties we use, doesn't it? Biomechanics.
Definitely. 2 key concepts: stress relaxation and creep.
Explain those quickly.
Okay, stress relaxation is, well, if you stretch the skin and hold it, the force needed to keep it stretched decreases over time. Creep is when you apply a constant force and the skin slowly stretches, gaining surface area.
And these are the principles behind tissue expansion, basically.
Exactly. They allow the skin to accommodate the expander over time.
So when we reconstruct, what are our main goals? High level.
Number 1, tension-free closure. Absolutely critical for healing. Then, maintain function motor and sensory if possible.
Restore a natural contour, match the hairline, keep brow symmetry, the aesthetic side.
Very important. And fundamentally, you're protecting what's underneath the cranium, the dura, the brain.
Okay, guiding principles for achieving those goals.
Well, first, the classic. Replace like with like. Use scalp to replace scalp whenever you can.
Makes sense. Keeps the hair-bearing quality.
And when designing flaps, you absolutely want to try and include a major named scalp vessel that maximizes your chance of survival.
Where's the best place to get mobile tissue from?
The parietal scalp generally offers the most mobility. That's because the superficial temporal fascia, or TP fascia, glides over the deep temporal fascia there. Makes it a great donor site for local flaps.
Right. And in trauma, back to that point about debridement, be cautious initially.
Very cautious, clean it up, see what survives. The vascularity is your friend.
What if local tissue just isn't enough?
That's where tissue expansion comes in. It's invaluable for larger defects.
Allows you to generate more adjacent hair-bearing skin.
Exactly. You can gain a lot of surface area. It's also useful, say, if you have exposed bone, you might temporarily cover with a skin graft after burring down the outer table.
To get a vascular bed.
Or use a pericranial flap and then plan for expansion later for definitive coverage.
Any downsides to expansion?
Well, it can thin the hair follicles, leading to decreased hair density. That's something to counsel patients about.
And contraindications.
Definitely avoid it in previously irradiated scalp or acutely infected areas. The tissue just won't tolerate it well.
You mentioned flaps. Sometimes you need a bit more length or stretch. Glial scoring.
Ah, yes. Making multiple small cuts through the glia, perpendicular to how you want to stretch it. It helps release tension, gain a centimeter or two sometimes.
But the strength of the closure.
Still relies on approximating the glia. That's the layer that holds everything together. The skin closure is less critical for strength.
What about skin grafts? Can they take directly on bone?
Only if there's a vascularized bed. So if the pericranium is intact, yes. If it's gone, you need to burr the outer cortex of the skull.
To stimulate granulation tissue.
Precisely. Then the graft can take on that bed. And sometimes, honestly, healing by secondary intention over bone, especially smaller areas, can give surprisingly acceptable results, though it takes time.
Okay, let's run through options based on defect location, starting anteriorly near the forehead and hairline.
Small anterior defects. Often primary closure works, or simple advancement or rotation flaps. Keep the hairline in mind.
Moderate size.
Things like VY advancements, maybe subcutaneous pedicled flaps, or carefully designed rotation flaps. You might consider temporoparietal occipital flaps, the TPO flap, to bring hair-bearing tissue forward and maintain that hairline.
And for large anterior defects.
Now you're looking at larger rotation flaps, maybe needing a skin graft on the donor site, a back graft. Orticochea flaps are described, but can be cosmetically challenging. Often tissue expansion is really the best bet here for a good aesthetic outcome.
Makes sense. Moving laterally to the parietal region.
Parietal defects benefit from that scalp mobility we mentioned. Small ones, primary closure, VY, rhomboid flaps work well.
Medium.
Rotation advancements, bilode flaps are good options. You can really move tissue effectively here.
Large parietal defects.
Tissue expansion is often preferred aesthetically. You can do large single-stage closures with things like big bipedical fronto-occipital flaps grafting the donor site. But, well, the cosmetic result might not be ideal compared to expansion.
Got it. How about the occiput posteriorly?
A bit less mobile back there. Small defects, again, primary closure is often possible.
Medium occipital.
You might need rotation advancement flaps, bringing tissue up over the trapezius and splenius capitis muscles.
And large ones.
Larger rotation flaps, maybe an Orticochea 3-flap technique. But again, for superior results, especially contour and hair, tissue expansion is often the way to go.
Any other options for lower occipital or temporal defects?
Yeah, pedicled myocutaneous flaps, like trapezius flaps, can sometimes be useful if the defect extends down towards the neck or temporally.
Okay, the vertex. That's always tricky, right? Limited surrounding tissue.
It is. The bald spot area. Small defects, maybe primary closure, or pinwheel rhomboid flaps designed around the hair whorl if possible.
Medium vertex defects.
Those pinwheel rhomboid flaps become less useful. You might need double opposing rotation advancement flaps, or maybe rotate tissue up from the occiput, possibly with a back graft.
And large vertex defects. Big challenges.
Huge challenges. Often need large rotation flaps with extensive undermining, glial scoring, and back grafting. Tissue expansion is frequently preferred over complex flaps like the Orticochea for these really large vertex defects.
What if we're talking near total scalp loss?
Then you're almost always looking at free tissue transfer.
What are the common workhorse-free flaps here?
Latissimus dorsi is a big one, omentum, radial forearm, ALT, anterolateral thigh.
Pros and cons. Muscle flaps.
Muscle flaps like the latissimus provide great bulk initially, though they can atrophy over time. They offer good contour, and importantly, they bring in robust vascularity. This is especially good in radiated fields, may reduce CSF leak risk or extrusion risk if you're placing an implant underneath.
Other options for massive defects besides free flaps.
You could consider serial tissue expansion, doing it in stages, or using dermal regeneration templates like Integra, followed by skin grafting once it's vascularized.
What's the advantage of something like Integra?
Potentially less morbidity, shorter initial operative time compared to a big free flap. It adds some bulk and contour. It can be useful in, say, oncologic cases where you're waiting for final margins before committing to a complex free flap.
Okay. Secondary procedures.
Yeah.
Hair replacement is often needed.
Yes. Follicular unit grafting, or FUG, is generally the standard now. Much better results aesthetically, better graft survival compared to the older punch grafting techniques.
Right. Let's switch gears slightly to calvarial reconstruction. Protecting the brain, restoring contour. Options.
Broadly, autogenous using the patient's own tissue or alloplastic using synthetic materials.
Autogenous first. What do we use?
Split calvareal grafts are common, often harvested from the parietal bone because it's thicker and flatter. Split rib grafts are another option. Ribs have the advantage of regenerating if the periostem is left intact.
Benefits of autogenous bone.
It's biocompatible, integrates, good strength, resistant to infection. Downsides are potential contouring difficulties, some resorption risk, and donor site morbidity.
Oh, alloplastics.
Things like methyl methacrylate, PMMA, titanium mesh, hydroxyapatite cements, sometimes acrylic or PEEK implants.
Advantages of those.
Unlimited supply, no donor site issues, you can shape them precisely.
No, that's what I mean.
They don't integrate biologically. Higher risk of infection, especially long-term. Cost can be a factor, some are brittle.
What's improving things here? Technology.
Definitely. Computer-designed, patient-specific implants made from PEEK or titanium are becoming more common. They offer excellent contour matching and can reduce operative time. And of course, tissue engineering is the big hope for the future growing bone grafts in the lab.
So let's distill this down. Key takeaways for exam prep on scalp and calvarial reconstruction.
Okay. Remember the subgaleal plane for avulsions. Understand the rich scalp vascularity. It allows for bold flap design, but demands respect.
Know that the parietal scalp offers the most mobility for local flaps.
Galeal scoring can give you extra length. Always aim to avoid distorting the hairline and brow.
And consider tissue expansion early for large defects or when cosmesis is paramount. It's a really powerful tool.
Absolutely. Calvarial reconstruction. Weigh the pros and cons of autograft versus alloplast based on the defect and patient factors.
Excellent summary. So thinking about all this complexity, the layers, the vessels, the biomechanics, the different materials, what do you think is the next frontier? What innovative approaches might really refine scalp and calvarial reconstruction moving forward?
That's a great question to ponder. Perhaps better integration of tissue engineering or maybe advances in vascularized composite allotransplantation for the scalp. Lots to think about.
Indeed. Something for you all to consider as you continue your studies. Thanks for joining this deep dive.